Hi, and welcome to week 9, gastrointestinal. I did a case study on hemorrhoids. Here's my subjective data. The chief complaint was, I have a terrible painful hemorrhoid that will not go back in. The patient is a 64-year-old woman known to the clinic, seen today for a complaint of a hemorrhoid that is painful and bleeding. Patient reports streak of blood on the toilet paper to frank red blood in the toilet with bowel movements. Today, the patient's pain to the perirectal area is 7 out of 10. This reports a long multi-decade history, both internal. This patient reports a long multi-decade history of both internal and external hemorrhoids. She reports she has had internal hemorrhoids come out before, but she has always been able to push them back in after passing her bowels. Patient has tried preparation H to relieve the pain without success. She has increased pain with sitting and when trying to pass her bowels. There is some pain relief when patient is not sitting on her buttocks. Patient reports she has also had a long multi-decade history of chronic constipation. She reports she drinks 4 to 5 16-ounce bottles of water a day and takes stachycate sodium to soften her stool. However, the stool remains hard. She thinks the hard stools are a side effect of one of her psychiatric medications. However, she reports she is doing very well and does not want to have to change any of her psychiatric medications at this time. Patient reports she passes her bowels every 2 to 4 days. She spends an extended amount of time on the toilet, greater than 30 minutes when she does pass her bowels. That's a long time. Past medical history includes hypertension for more than 20 years, chronic constipation more than 20 years, bipolar affective disorder more than 20 years, depression and anxiety more than 20 years, arthritis of the hips and knees more than 10 years, hemorrhoids more than 10 years, and obesity most of her adult life. Current medications include lisinopril 40 milligrams daily, pantoprazole 40 milligrams daily, bupropion 75 milligrams twice a day, hydrochlorothiazide 12.5 milligrams daily, gabapentin 100 milligrams 3 times a day, Lamictal 25 milligrams 2 tablets daily, and Lexapro 10 milligrams daily. The Lamictal and the Lexapro are prescribed by her behavioral health provider. Her allergies include morphine and the reaction is vomiting, so it's probably more of a sensitivity, but she likes to list it as an allergy. Her surgical history includes tubal ligation in 1995, cyst removal, date unknown, patient reports over 10 years ago. The cyst was on her abdomen. Carpal tunnel release in 1989. Her social history includes she currently lives with her son and daughter-in-law in their house. They bought the house. She moved in with them to help them pay the mortgage. Her other adult son also lives in the home. She is single. She's never been a tobacco smoker, does not vape, denies use of alcohol or any other drugs. She sleeps about 10 hours a night. She says this is not a problem for her. She is not currently sexually active. She follows a regular diet. She eats what she wants. Patient admits that she does not eat many fruits or vegetables and does not follow a high fiber diet. Her family history includes diabetes, mellitus type 2 in her mother, lung cancer in her maternal grandmother, her mother and her sister, and heart disease in her father and mother. She was not able to tell me at what age her parents died. COVID immunizations. She did get the first 2 doses of Moderna in August of 21. She has not received a booster. She got her flu vaccine in October of 21. And per patient, her childhood vaccines are up to date. Her ROS includes general pertinent positive for perirectal pain, 7 out of 10. She denies fever, fatigue, change in appetite or activity. Cardiac denies dizziness, edema, palpitations, or chest pain. Respiratory denies dyspnea, wheezing, difficulty breathing, and cough. Gastrointestinal. She has pertinent positives for constipation with hard stool, internal and external hemorrhoids, streaks of blood when wiping, occasional frank red blood in the toilet. She does not understand why her stool softener doesn't work. She denies black tarry stool, abdominal pain, bloating, heartburn, or incontinence. Her GU denies urinary incontinence, pain with urination, dark cloud of urine, or foul odor of urine. Psychiatric, she denies depression, anxiety, suicidal ideation, self-harm, change in sleep pattern. Her objective data includes a blood pressure of 138/82 in her left arm sitting at rest, a pulse of 80, regular, a respiratory rate of 18, a temp of 97.6 Fahrenheit, an O2 set of 98% on room air. She is 198 pounds, 5 feet tall, with a BMI of 38.3. Her physical assessment includes she is alert, awake, and oriented times person, place, time, and situation. She has no acute distress. She's not in acute distress. She's well-groomed, well-nourished, appropriately dressed, and obese. Cardiac, regular rate and rhythm, normal S1, S2, no murmur, gallop, or rub noted, no edema to extremities noted. Respiratory, her lungs are clear to auscultation throughout all lobes, no rales, rhonchi, or wheeze noted. Gastrointestinal, her abdomen is soft, non-tender, and rounded. Visual rectal exam with multiple external hemorrhoids noted. She had a prolapse grade 4 internal hemorrhoid. On the outside of the rectum, the size of the hemorrhoid was about 2 centimeters coming out and about 1.5 in depth. It was very edematous appearing, very erythemic. The area around it was very painful to late palpation. The rectal opening was to the left of the hemorrhoid. It was very difficult to visualize because the hemorrhoid was quite large that was prolapsing out. Difficult to visualize or palpate. Patient was in way too much pain to do a rectal exam. I would defer that to GI. Percussion of the abdomen results in tympany throughout all 4 quadrants. No pain with light or deep palpation, no organomegaly noted. Psychiatric, patient is calm with appropriate demeanor. Assessment. The patient is a 64-year-old woman who presents to the clinic with a long history of constipation and internal and external hemorrhoids, who today has a prolapse 4th-degree hemorrhoid. The hemorrhoid is painful, edematous, erythemic, and tender to touch. So my diagnoses of assessment was a 4th-degree hemorrhoid, and I chose as differential diagnoses to either a 3rd-degree hemorrhoid, although I really don't think so because it would not go reduce back into the rectum, and rectal cancer because that would be a do not miss diagnosis. However, I've seen rectal cancer multiple times and it did not look like that to me. That doesn't mean it's not. The second diagnosis was prolapse of rectal mucosa, and the third is chronic constipation. The plan followed. The patient was prescribed nitroglycerin, 2% transdermal ointment, 1 inch topically to the hemorrhoid and really the hemorrhoid area, especially the perirectal area, every 12 hours, and lidocaine 5% external cream topically twice a day to the area. Instruct the patient to wash your hands thoroughly before and after applying the cream, instructed on dose, frequency, and duration of medication. Nitroglycerin ointment may stain clothing, so she may want to protect her underwear. The patient verbalized understanding. The patient was instructed to take a sitz bath twice a day for relief. And I did actually tell her after bowel movements too. Instruct a patient on how to use a sitz bath. She has used them in the past since hemorrhoids have been a recurring issue for her. And she verbalized understanding of instructions. Patient was referred to colorectal surgeon to evaluate and treat the hemorrhoid. Information for referral was provided to the patient with instructions to call the clinic if she has any problems scheduling an appointment, and the patient verbalized understanding. Follow-up appointment in 1 month to reevaluate. Patient instructed to return sooner should symptoms increase, and the patient verbalized understanding. We did discuss with her that if she has an appointment with a colorectal surgeon, she's doing okay. She doesn't need to come back in a month. But if she doesn't get in with one, then we would like her to be back. Further plan included an instruction on non-pharmacological methods to relieve pain with hemorrhoids, such as using a pressure redistributing or offloading cushion when sitting. I did describe to her what I meant. I leaned away. I actually encouraged her not to go with a donut. Never been a fan of donuts, and it kind of puts pressure around the affected area, and then you're cutting off blood flow to what's in the middle of that donut. I did explain to her what an offloading or redistributing pressure cushion was, just like a low density foam. Also recommended leaning towards the side or laying down to relieve pressure which will help relieve pain, and the patient verbalized understanding. Instruct the patient on the importance of softening stool to prevent a recurrence of prolapsed hemorrhoids. Instructed to soften stool with increased fluids and fiber. Instructed on foods high in fiber, such as fruit, vegetables, and fortified foods. Instructed patient on taking over-the-counter Marilac 17-gram capsule daily to soften stool. Patient states she has Marilac at home and will consider taking it. She will try to increase her fruit intake and report she does not eat many vegetables and probably will not eat more. Patient did verbalize understanding of the instructions. I really did spend some time talking to her about controlling her constipation. That's definitely a common finding in hemorrhoid patients, especially those at the grade 3, grade 4 level, but all of them really. So guidelines followed. The American College of Gastroenterologists guidelines. I feel like this was kind of more so on a GI perspective. Medical management began with prevention of constipation, increased fluid and fiber intake, recommend stool softeners and polyethylene glycol, which we did. Reduce time sitting on the toilet to avoid straining. No topical medications, but there were no topical medications in their guidelines. The surgical management of their guidelines were for grade 1, 2, and some grade 3 internal hemorrhoids can be treated in the office with a rubber band ligation. Grade 4 requires a hemorrhoidectomy. Up to date recommends medical management, again, with prevention of constipation. They did recommend sitz baths after defecation for pain control. Also report topical nitroglycerin can help reduce pain by reducing anal sphincter spasms, and recommends the use of a topical analgesic such as lidocaine to decrease pain. So we kind of use the mix of both of these guidelines. Up to date also recommends referring to a specialist when symptomatic, so painful, but unpainful bleeding is usually a symptomatic grade 1 or grade 2. Refer if they don't respond to treatment in 6 to 8 weeks. Symptomatic grade 3 and grade 4 hemorrhoids should be referred to a specialist, and thrombosed hemorrhoids. Although from what I read, many external thrombosed hemorrhoids, they're painful when it happens, but they resolve on their own after a short period of time. So there was kind of they did put a little more detail into that. As long as the hemorrhoid's only been thrombosed for less than 3 days, more than 3 days, they said just leave it alone, it'll go away. There are 2 different types of hemorrhoids, so internal hemorrhoids and external hemorrhoids. The difference is really the dentate line, and if you look at the picture on the bottom right, it shows you where the dentate line is. So hemorrhoidal veins are a normal structure in the lower rectum. Internal hemorrhoids originate from above the dentate line and are insensate. However, pain may occur when a prolapsed hemorrhoid sits on the external epithelial tissue, exposing the skin to moisture and stool, resulting in irritation. So I honestly think that most of the woman's pain was her skin around the hemorrhoid, or especially at the rectal opening, was also red and irritated. Internal hemorrhoids are graded on a scale of 1st to 4th degree. External hemorrhoids originate from below the dentate line and are covered with squamous epithelium, causing them to be sensate with pain receptors, and often become very painful when thrombosed. After thrombosed, external hemorrhoids appear as skin tags. I don't know about you guys, but I've seen that many, many times. External hemorrhoids are not graded. You can almost see in this picture, that's a external hemorrhoid that's currently thrombosed, but if you look below, it looks like what looks like a skin tag to me. I wonder if that was a previous one. Okay, so this is the grading of internal hemorrhoids. If you start on the left, grade 1 hemorrhoids project into the anal canal and often bleed but do not prolapse. Grade 2 hemorrhoids may protrude beyond the rectum with straining or defecation, but reduces spontaneously when straining is complete. Oops. Grade 3 hemorrhoid produced spontaneously or with straining and require manual reduction. So this is what I think the patient was describing previously to this grade 4 hemorrhoid. So the grade 4 hemorrhoid chronically prolapse and it can't be reduced. They usually contain both internal and external components and may present with acute thrombosis or strangulation. I don't think her hemorrhoid was thrombosed or strangulated, but it was angry looking. So there are a couple of surgical treatments for grade 3 and grade 4 with her internal hemorrhoids. It's just what we expect will probably be the case with this patient. The most common postoperative complaint after hemorrhoidectomy in 80% of patients is pain, which increases physical and psychological stress. A hemorrhoidectomy is the surgical removal of the hemorrhoid from the hemorrhoidal vascular cushion by excision or electrocautery. Pain is usually mild for the first few days and exacerbates with bowel movements. Although it's not, stapled hemorrhoidopexy involves removing a portion of the mucosa and some mucosa about 4 to 5 centimeters above the dentate line with a circular stapler specific for this procedure. The distal mucosa is stapled up to the proximal mucosa, which cuts off the arterial blood supply to the hemorrhoids, resulting in shrinkage of the hemorrhoid plexus. Pain is most severe at the first 72 hours after procedure. Bowel movements do not exacerbate pain. Some of the stuff I read is not in agreement with all of this. I have seen the device they use to reverse ostomies, which is also like a circular stapler. So it kind of goes up and then it has staples all around the whole chamber. And when it shoots out, it just connects and staples the whole round area together. So what this does is it pulls it up and pulls some of that even sagging mucosa up further, so it's not coming out past the rectum. Hemorrhoid artery ligation is the third treatment they do to remove hemorrhoids. It's a Doppler guided to ligation of the arteries that feed the hemorrhoidal cushions. Hemorrhoidopexy, it's Doppler guided ligation of the arteries that feed the hemorrhoidal cushions. Sometimes a hemorrhoidopexy, but they do a sutured version, may need to be performed after if too much mucosa is remaining. Pain is usually most severe in the first 72 hours after procedure. Bowel movements do not exacerbate pain. Pain after hemorrhoidectomy, whichever one you do, there's varying documentation on how much pain there is. Pain is subjective. We all know this. So an article I found interesting on future research. There was a study, a double-blind study I found called The Effect of Perianal Tramadol Infiltration on Postoperative Pain Following Hemorrhoidectomy. Again, it was a double-blind clinical trial. There were 90 patients with grade 3 or grade 4 internal hemorrhoids undergoing hemorrhoidectomy. Patients were assigned to one of three groups: the control group, who were infiltrated with normal saline prior to their hemorrhoidectomy, the bupivacaine group, and the tramadol group. They did exclude some patients outside of the study. These were patients that were using opioids chronically, patients who were morbidly obese. I forget what else. Prior to surgery, patients receive a perianal infiltrate of normal saline, bupivacaine, or tramadol, and then data was collected and compared for severity of postoperative pain, length of stay of surgery, length of surgery, pain at first defecation, length of time until request for additional analgesics, nausea, vomiting, and analgesic intake. So the findings: duration of surgery time was similar in all three groups. And ages were also similar. Significant differences noted in post-op pain scores amongst all three groups. The tramadol group had the lowest pain score, followed by the bupivacaine group and the control group, which was the normal saline group. Pain on first defecation was also decreased in the tramadol group when compared to the control group. However, There was not significant difference when compared to the bifurcating group, to the tramadol group or the control group. So pain on defecation was better with tramadol when compared to saline, but when compared to bifurcaine, there was not a significant difference between the bifurcaine and the tramadol or the saline. Time to first request for analgesics was significantly longer in the tramadol group than the other two groups, and no post-op nausea or vomiting was noted in any of the groups. Analgesic intake was also decreased for the tramadol group when compared to the other two groups. So in conclusion, the use of rectal tramadol infiltrate prior to hemorrhoidectomy decreases post-operative pain, prolong the time to the first request for analgesia after surgery, reduce pain scores at the first defecation, and decreases analgesic intake after surgery. So it was concluded that the use of tramadol infiltrate prior to hemorrhoidectomy can be suggested for an effective method to decrease postoperative hemorrhoidectomy pain. And here are my reference list. It's also in my soap note that will be posted with this. And I look forward to your comments and questions. Thank you very much. I hope you enjoyed this presentation. We'll see hemorrhoids. They're pretty common. Enjoy your day. If I can get the recording to stop.